What the study says.
Welcome back to the deep dive. We've got quite a stack of research and review articles here today.
We certainly do, and we're planning to really get into them.
Exactly. We're going to unpack what they tell us about a topic that, well, it affects a lot of people, but isn't always the easiest thing to talk about. Male sexual dysfunction.
That's right. We're looking at the science here, the clinical findings in this material, trying to understand these conditions not just as, personal problems, but as complex medical issues.
Right, with real causes, specific ways to diagnose them, and a whole range of treatments that the current research actually supports.
Yeah. So think of this as a way to get up to speed on what the evidence is saying right now.
Our mission, then, is to pull out the key findings, sort through the information, and help you get a clearer picture of male sexual dysfunction and its impact.
Okay, so where do we start? First off, I think we need to define what we're actually discussing. Male sexual dysfunction, it's not just one single thing, is it?
No, it's definitely a broad term. It covers several specific conditions. And the sources we looked at, they mostly zero in on erectile dysfunction, ED, and different kinds of ejaculatory disorders.
Right, the ejaculatory issues, and even those aren't all the same. One of the papers had quite a useful visual, actually.
Oh, yeah, the continuum thing, like a spectrum for ejaculation.
Exactly that. So picture a line. On one end, you've got premature ejaculation, PE. Smack bang in the middle is, well, what's considered normal ejaculation.
Okay.
Then, as you move along the line, you get to delayed ejaculation, DE, and right at the far end, an ejaculation, which is basically the complete absence of ejaculation.
And what about retrograde ejaculation? Where does that fit?
Good point. That's where semen goes backward into the bladder instead of out. The source mentions it can technically happen anywhere along that spectrum. It's sort of a separate mechanical issue.
Okay, got it. So let's define these a bit more based on the research. ED seems pretty clear-cut. The consistent inability to get or keep an erection that's firm enough for, well, satisfactory sexual performance.
Right. And for PE, premature ejaculation, the research defines it by persistent ejaculation that happens too early and causes distress.
It has to be persistent, right? Like
Yeah.
happening almost every time for a while.
Typically, yes. Often occurring on nearly all occasions and usually for at least 6 months. But what's really interesting and important for people to know is how it's diagnosed.
It's not just about timing, the IEL.
Exactly. While the intravaginal ejaculatory latency time, or IELT, that's a key measure they use in studies, the actual clinical diagnosis, that leans heavily on your history.
So the doctor asks about how long it's been going on, how often?
And crucially, the level of distress it's causing. For you or for your partner, that distress component is key.
And is it similar for delayed ejaculation, DE? That distress is important.
Yes, very similar in that regard. DE is defined as a marked delay in ejaculation, or maybe it happens really infrequently or sometimes not at all.
And it causes personal distress.
Precisely. Again, it comes back to that history and the impact it's having on the person.
So how common are we talking here? Are these widespread issues?
Well, the stats in the material suggest they're pretty prevalent. For example, decreased libido, low sex drive, which is part of overall sexual function.
Yeah.
That's reported in about 13 to 17% of men aged 18 to 59. And those figures tend to climb as men get older.
And the impact, it's not just physical, is it?
Yeah.
The research really seems to stress that.
Oh, absolutely not. It goes way beyond the physical act. We're talking about a significant hit to quality of life, overall sexual functioning, satisfaction, and it often causes real personal distress.
And relationship problems too, presumably.
Definitely. Interpersonal difficulty, strain on relationships, that comes up a lot in the research. And it affects both partners, not just the man experiencing the dysfunction.
Which brings us to another point. The sources mentioned the reluctance to actually talk about it.
Yeah, that's a big hurdle. The literature notes that men are often hesitant to bring these things up with their doctor. And, well, sometimes clinicians might not initiate the conversation either.
So it kind of gets swept under the rug sometimes.
It can, yeah. Which is unfortunate given the impact and the fact that there are often things that can be done.
Okay, so let's dive into the why.
Yeah.
What causes these problems? The research we reviewed covers quite a few potential factors, right?
It does, and it's rarely just one thing. Often it's a combination, and for some conditions like PE, the exact cause, while it's still being figured out, probably multifactorial.
So what are the main categories the research discusses?
Okay, several broad areas. First up, and this is a big one, especially for ED vascular factors, things related to blood flow.
Ah, the plumbing, so to speak.
Kinda, yeah. And this is a really crucial takeaway from the sources. ED can actually be an early warning sign for underlying cardiovascular disease. Heart disease, basically.
Wow, okay, so trouble in the bedroom could genuinely signal trouble with your heart or blood vessels down the line.
That's exactly what the research suggests. Studies show ED increases the risk of future cardiovascular events, things like heart attacks, strokes, and even overall mortality.
That's pretty serious. What are the risk factors they mention?
A lot of the usual suspects for heart disease, actually. Age, diabetes, high cholesterol, high blood pressure. Already having heart or vessel disease, obesity or high BMI, metabolic syndrome.
Lack of exercise, smoking.
Yep, those two. And interestingly, some medications for cardiovascular conditions can impact erectile function. Certain diuretics, some older beta blockers, though not all, like nebivolol seems okay.
But others are fine or even helpful.
Right, things like ACE inhibitors, ARBs, calcium channel blockers, they seem to have neutral or maybe even slightly beneficial effects on erections, according to the sources.
Okay, so vascular is key. What's next?
Hormones.
Hormonal influences, yeah.
Yeah.
Low testosterone hypogonadism gets discussed quite a bit. It's particularly linked to decreased libido and also ED.
So low T can cause low sex drive and erection problems.
Typically, symptoms like low desire, maybe fewer spontaneous erections like morning wood and ED itself are often associated with low testosterone levels.
How do they check for that? The clinical guidelines mentioned usually recommend measuring total testosterone levels in the blood, specifically fasting in the morning, and often on more than one occasion to confirm.
Just testosterone. Or other hormones, too.
Good question. They usually check other related hormones too, like prolactin, LH, TSH for thyroid function, and sometimes estradiol. It's part of a bigger picture.
And if someone does have low testosterone, therapy helps.
It often helps with low libido if testosterone is genuinely low. But the research points out there's not strong evidence it helps men with normal testosterone levels. And importantly,
Yes.
testosterone therapy doesn't seem to be effective for ejaculatory disorders like PE or DE. So even if low T is associated with those, it doesn't look like a direct cause and effect relationship there.
Interesting. Any other hormonal links?
Yes. Hyperthyroidism and overactive thyroid has been linked specifically with acquired PE, so PE that starts later in life. And the sources say that often gets better when the thyroid levels are corrected.
Okay. Now, this next area sounds fascinating, the neurobiological stuff. Brain chemistry and nerves.
Right. Ejaculation is, it's a really complex process involving signals in the brain and the nervous system. The research talks about key neurotransmitters.
Like dopamine and serotonin.
Exactly. Broadly speaking, dopamine seems to facilitate or help trigger ejaculation, while serotonin tends to be inhibitory. It helps put the brakes on, essentially.
And is that linked to theories about PE, premature ejaculation?
It does. A major hypothesis discussed is that men with PE might have differences in how sensitive certain serotonin receptors are in their brain. Maybe some receptors are less sensitive, like the 5-HT2C type, or others are more sensitive, like the 5-HT1A type.
And the fact that SSRI drugs, which affect serotonin, often help delay ejaculation, that supports this idea.
Precisely. It fits quite well. Other ideas explored in the research include things like maybe the gland's penis itself is hypersensitive, or there are differences in how the brain processes the nerve signals coming from the penis. It's complex.
What about the mind? Psychological factors. I mean, didn't people used to think PE was purely psychological?
That was definitely the old review, yeah. Now, the research acknowledges that psychosocial factors, things like performance anxiety, relationship problems, general life stress, work stress, are often associated with these conditions, especially PE.
But not necessarily the root cause?
Not definitively confirmed as the primary cause, no. It's often more complicated, like a two-way street. The condition itself can make anxiety or relationship stress much worse, creating this kind of negative cycle.
I see. What about for delayed ejaculation or anejaculation? Are psychological factors discussed there?
They are mentioned. The literature touches on potential psychological conflicts like fear or guilt related to sex or intimacy, but the sources also point out that there's a real lack of large-scale studies evaluating psychological treatments specifically for DE and anejaculation, so less evidence there.
Okay. And finally, can other medical conditions just generally contribute?
Oh, absolutely. The research lists quite a few conditions frequently linked with ED or ejaculatory problems. Things like prostatitis, inflammation of the prostate, seems more common in acquired PE.
We mentioned thyroid disorders already.
Right. Also, chronic pelvic pain syndrome, lower urinary tract symptoms, LUTS, like trouble peeing depression, chronic kidney disease.
Sleep problems, too.
Yes, various sleep disorders, including sleep apnea, are mentioned, and even things like psoriasis, inflammatory bowel disease, gouty arthritis, a whole range of conditions listed in the material seem to have some association.
It really shows how connected everything in the body is, doesn't it?
It really does. A problem in one area can definitely be linked to or influenced by something seemingly unrelated elsewhere.
Okay, so let's shift gears. Someone experiences these issues, they go to the doctor. How do clinicians actually diagnose what's going on based on this research?
Well, the absolute cornerstone of the diagnostic process, emphasized again and again in the sources, is taking a thorough history.
Just talking.
A detailed conversation, yes, about your sexual history, what's been happening, when it started, how often. Also, psychosocial factors, stress, relationship dynamics, and of course, a full medical history, including medications. For PE and other ejaculatory disorders especially, the diagnosis is largely history-based.
Do they use questionnaires? I've heard of those.
Yes, questionnaires are frequently mentioned as really useful tools. They help assess the severity of the problem, track symptoms over time, and see if treatments are working.
Which ones?
For ED, you often see the IIE International Index of Erectile Function, or the shorter version, the SHIM Sexual Health Inventory for men. For PE, there are tools like the PEDT Premature Ejaculation Diagnostic Tool or the PEP Premature Ejaculation Profile.
So history, questionnaires, then a physical exam and lab tests.
Correct. The workup typically includes a focused physical exam, checking the thyroid, abdomen, genitals, feeling pulses in the legs. And lab tests are pretty standard, particularly when looking into ED or if hormonal issues are suspected.
Like the testosterone test we talked about.
Exactly. Fasting morning, total testosterone, usually along with prolactin, LH, blood sugar, cholesterol levels, TSH for thyroid, creatinine for kidney function, maybe PSA depending on age and risk factors. Urinalysis is common too.
Are there ever more sort of specialized diagnostic tests used?
Sometimes, yes, though maybe not routinely for everyone right away. The material mentions things like duplex ultrasonography, using ultrasound to look at blood flow in the penis, or penile tumescence studies, like the Rigispan, which monitors erections during sleep.
Chest injections.
Yeah, sometimes injecting a small amount of medication to see if it induces an erection, which helps assess blood vessel function. But these are usually for more complex cases or when initial treatments haven't worked.
Okay, that makes sense. Let's pivot now to treatments. What does the research say actually works? What options are out there?
There's quite a range, actually, and the level of evidence supporting them varies. But a really fundamental starting point, strongly recommended across the board, is lifestyle modifications.
Ah, the basics. Diet, exercise, quitting smoking.
Precisely those. Increasing physical activity, losing weight if overweight, stopping smoking, managing those cardiovascular risk factors we discussed earlier.
And the timing is important.
Yes, the research suggests starting these lifestyle changes at the same time as, or even before, initiating other specific treatments for ED. They're not just optional add-ons, they're seen as foundational.
Makes sense. What about psychological or behavioral therapies?
They definitely have a role, especially if psychological factors are contributing or if the condition itself is causing distress. Psychotherapy can be helpful for things like low libido or perhaps DE and anejaculation if psychological issues are suspected.
And for PE, premature ejaculation.
For PE, specific behavioral techniques are often used. You might have heard of the stop-start technique or the squeeze technique. Sometimes these are done with a partner, sometimes alone, maybe using devices.
Did it work?
They can. And some research actually suggests that combining behavioral therapy with medication might be even better for PE than using either one by itself.
Interesting. Any specific studies mentioned?
Yeah, there was one interesting study comparing regular penis root masturbation versus Kegel exercises for primary PE. It found both had some therapeutic effect, but in that particular study, the masturbation technique seemed potentially a bit more effective. Needs more research, of course.
Okay. Now, the big one, probably. Pharmacological treatments.
Yeah.
Medications.
Absolutely. This is a huge area in the research. Let's start with ED. For erectile dysfunction, the first-line medical therapy recommended is usually PDE5 inhibitors.
Phosphodiesterase 5 inhibitors. Those are the common pills, right? Sildenafil, tadalafil.
Exactly. Sildenafil, vardenafil, tadalafil, and avanafil. They work by helping to increase blood flow into the penis when a man is sexually stimulated.
How do they do that again?
They increase levels of a chemical called CGMP, which relaxes the smooth muscles in the penile arteries, allowing more blood to flow in. They're popular because studies show they work well for many men and they're relatively easy to take.
Are there differences between them?
Some, yes. Sildenafil is known for having a much longer duration of action, sometimes working for up to 36 hours, which some men prefer. Obenvelef might have a slightly quicker onset of action.
And the research highlights a really, really crucial warning about these drugs, doesn't it?
Absolutely critical. You cannot take PDE5 inhibitors if you are also taking medications containing nitrates.
Nitrates are often used for chest pain, right? Angina.
Combining them can cause a sudden, severe, and potentially life-threatening drop in blood pressure. It's an absolute contraindication. You also need to be cautious of taking alpha blockers, often used for prostate issues or high blood pressure.
But generally, they're effective, even for men with other health issues.
Yes. Clinical trials show they're effective for many men, including those with diabetes or who've had treatments like prostate surgery or radiation, although success rates might vary.
Okay, what about medications specifically for premature ejaculation, PE?
Here, the research talks a lot about using certain SSRI antidepressants off-label.
SSRI, selective serotonin reuptake inhibitors, like for depression or anxiety.
The very same class of drugs, yes. Medications like paroxetine, clomipramine, sertraline, fluoxetine, citalopram, they're typically taken daily for PE.
And they work by affecting serotonin, which we said helps delay ejaculation.
That's the idea. And studies show they are often effective and generally well tolerated. Paroxetine in particular often shows a significant delay. One study cited found roughly an 8.8-fold increase in IELT.
How quickly do they work?
The delay usually starts becoming noticeable within about 5 to 10 days of daily use, with the maximum effect typically seen after 2 or 3 weeks.
Is there anything specifically for PE, not off-label?
Yes, there's duloxetine. It's also an SSRI, but it's shorter acting and specifically developed and approved in many countries for on-demand use for PE. So you take it a few hours before sex rather than every day.
Does it have side effects?
Common ones mentioned in the research include nausea, diarrhea, headache, dizziness. These tend to be dose-related.
Any other approaches for PE besides pills?
Topical anesthetics are another option discussed. These are creams or sprays, like Imole cream or Tempest spray, that you apply directly to the head of the penis before intercourse.
How do they work? Just numb it a bit.
Essentially, yes. They reduce sensitivity. Studies show they can effectively increase IELT. But potential downsides include, well, reducing sensation may be too much for either partner. And if left on too long or too much is used, they could potentially interfere with the erection itself.
Okay. Now, what about the other end of the spectrum, delayed ejaculation or anejaculation? Are there good medications for those?
This is where the research indicates things are much more limited, unfortunately. Pharmacological options for DE and anejaculation are currently few and far between.
Not many effective drugs.
Not really established ones, no. There are very few large-scale studies, and the ones that exist often show pretty limited effectiveness or come with significant side effects.
What kinds of drugs have they tried?
The sources mention explorations with various medications in smaller studies or case reports, things like yohimbane, buspirone, methenical. Even some ADHD medications like Adderall or lisdexamfetamine have been tried based on their potential mechanisms. But the consensus is clear. Much more evidence is needed before these can be recommended routinely.
So not much solid ground there yet.
Yeah.
Did the research mention any other oral meds tried for PE?
Briefly, yes. Tricyclic antidepressants like clomipramine, which also affects serotonin and norepinephrine, and tramadol, which is an opioid pain reliever but also has effects on serotonin, have both been evaluated for PE.
Did they work?
They showed some efficacy in studies, but they also come with their own sets of potential side effects that need to be considered carefully.
Okay, moving beyond pills. What about device therapies?
For ED, vacuum erection devices, VEDs, are discussed. These are basically cylinders placed over the penis with a pump that creates a vacuum, drawing blood in. Then a constriction ring is placed at the base to maintain the erection.
Are they effective?
They can be quite effective, actually. Studies report success rates for intercourse up to 90% in some cases. They're often considered a second-line option if pills don't work or aren't suitable.
Any downsides?
Common side effects include pain, bruising, sometimes the penis feels cold, and the ring can sometimes interfere with ejaculation. They're also not usually recommended for men with bleeding disorders or those taking anticoagulants, blood thinners.
Okay. And then there are treatments involving direct injection or insertion into the penis.
Yes, injectable or intraurethral therapies. These are usually alternative first or second-line medical options for ED.
How do they work?
The most common is penile self-injection, where the man injects a drug, usually alprostadil, directly into the side of the penis using a tiny needle. Or there's intraurethral epoprostenol, where a small pellet of the drug is inserted into the opening of the urethra.
Do they work well?
They can be very effective, even when pills haven't worked. But they have potential drawbacks, too, like pain, scarring, and, importantly, a risk of priapism.
Priapism, that's a prolonged erection, right?
Exactly. An erection lasting several hours, which is a medical emergency and needs immediate treatment to prevent permanent damage. That's a key risk patients need to be aware of.
So when do doctors start considering surgical treatments?
Surgery for ED is generally kept for men who can't use or haven't had success with any of the less invasive medical therapies we've discussed.
What's the main surgical option?
The primary one discussed is implanting a penile prosthesis or penile implant. These can be either inflatable devices, which are more complex but allow for a more natural appearing erection and flaccidity, or simpler semi-rigid rods.
Are patients happy with them?
The research generally reports high satisfaction rates, provided patients are well informed and have realistic expectations. Appropriate counseling beforehand is key.
Any major risks?
As with any surgery, there are risks. The material specifically highlights infection as a significant potential complication that can sometimes require removal of the implant.
Is there any other surgery for ED, like fixing blood vessels?
Penile revascularization surgery is mentioned. That aims to surgically bypass blocked arteries to improve blood flow. However, the research notes its success rates are often limited, and it's generally only considered for a very select group, usually younger, healthy men with specific, localized arterial blockages due to injury, for example. It's not routinely recommended.
Okay. Now, we also saw research looking into traditional, complementary, and alternative medicine, TCAM. What did that cover?
Yeah, there was a review focusing on TCM specifically for ejaculatory disorders. Interestingly, almost all the studies they found looked at PE. Very few on retrograde ejaculation, and none at all on DE or N-ejaculation.
What kind of TCM approaches were studied?
It was pretty broad. Things like lifestyle interventions, yoga specifically, various herbal supplements taken orally, topical herbal creams or applications, acupuncture and electroacupuncture, vitamins and minerals, even things like hyaluronic acid injections into the penis and music therapy were mentioned.
Wow, quite a mix. What was the conclusion? Do these things work?
Well, the review pointed out a major issue. The studies themselves were really varied, heterogeneous, using different methods, different products, and many had a high risk of bias.
Meaning the results might not be reliable.
Exactly. So while many of the individual studies reported better outcomes compared to placebo, the reviewers strongly emphasized the need for much better research, more standardized, rigorous, high-quality studies before we can really say if these TCM approaches are effective or safe.
So proceed with caution there. What about herbal supplements for ED sold online? Any research on those?
Yes, other research noted that many herbal products marketed online for ED make big claims, but often there's little or no actual scientific evidence to back them up, and sometimes the reviews promoting them might not be entirely genuine, so definitely buyer beware there.
Good to know. Finally, looking forward, were there any emerging therapies mentioned? Things still in development?
Stem cell therapy was highlighted as an area getting a lot of research interest, particularly for potentially restoring erectile function after damage, say from surgery or diabetes.
How would stem cells help?
The main types being studied are mesenchymal stem cells, MSCs, and adipose-derived stem cells, ASCs, often taken from fat tissue. The theory is they might work by reducing inflammation, releasing growth factors, and potentially helping nerves and blood vessels regenerate.
Is it ready for prime time?
Not yet, no. The research is clear that this is still very much experimental. A lot more study is needed to figure out if it's truly safe and effective and for whom it might work best.
Wow. Okay, that covers a huge amount of ground. From definitions and impact through all the potential causes, how doctors diagnose it, and this incredibly wide spectrum of treatments.
It really is a comprehensive look. I think the main takeaway from diving into all this material is that male sexual dysfunction, whether it's ED, PE, DE, or low libido, it's common, it's often complex, and the causes can be really diverse and frequently overlap.
Which means a thorough evaluation is crucial to figure out what's really going on for an individual.
Absolutely. But the good news, as the research shows, is that while it can feel like a difficult or isolating thing to deal with, there is a range of potential solutions.
From lifestyle changes and behavioral stuff right through to medications, devices, and sometimes surgery, all with different levels of evidence behind them.
Exactly. And that's why relying on evidence-based information and having that open, honest conversation with a healthcare provider is just so important. Understanding the potential causes and the options, actually backed by research, can be incredibly empowering for you.
Definitely. So here's a final thought to chew on. Looping back to that really striking connection we discussed between ED and cardiovascular health.
Yeah, that link is powerful.
What is that connection between something seemingly specific, like erectile function and the overall health of your heart and blood vessels, really tell us about our bodies? It just hammers home how interconnected everything is, doesn't it?
It really does. It suggests the body isn't just a collection of separate parts, but a truly integrated system.
So could paying attention to or treating a health issue in one area actually give us unexpected clues or even benefits for parts of our health that seem totally unrelated?
That's a fantastic question to ponder. It challenges us to think more holistically about health and disease, doesn't it? Seeing symptoms not just as isolated problems, but potentially as signals from the entire system.
Absolutely. It really underscores the complexity and the ongoing journey of research trying to unravel all these intricate connections within us. Makes you appreciate the work being done.